Today, we will consider the scenario of a child absconding from hospital. We will look at the reasons it happens, measures at prevention, and the steps to take when it happens to you in your emergency department. Hi, my name is Carl. I am a paediatric emergency medicine doctor. If you are a health professional and find these videos helpful, please consider subscribing. The first important take-home point is that every child, no matter the circumstance, is at high risk if they abscond. Adult patients may come and go as they please unless 1. They are detained under the Mental Health Act, 2. They are assessed as lacking capacity under the Mental Capacity Act, or 3. They are a prisoner in custody. If an adult has capacity and there is no risk to themselves or others, generally speaking, they have this choice, even if circumstances are not ideal, though they may be encouraged to sign a self-discharge form. Children, on the other hand, are different. Even the adolescent with capacity, aged 16 to 18, or the child with Gillick competence, under 16, may be considered high risk if they abscond or go missing. So why do children abscond? There are many factors to consider as shown. One important cause is perceived or actual negative regard towards them. When staff display negative attitudes, children may feel judged or misunderstood, prompting them to abscond as a way to escape emotional discomfort or rejection. Conversely, when staff show genuine warmth and respect, children feel accepted and secure, which helps build trust and establish the care setting as a safe space for therapeutic work. So can you actually prevent someone absconding? The answer is both yes and no. If someone is determined to leave, it can occur unexpectedly and without warning. Triage should therefore occur as early as possible for a child who may be expected not to wait. Triage documentation should include self-harm risk, absconding risk, a cursory assessment of capacity, a detailed description of their appearance, telephone numbers, details of next of kin, and addresses. Following triage, preventative measures include gaining a rapport with the person, discussing their care plan, agreeing their care plan, showing empathy, providing basic needs like food and drink. All such interactions build positive regard and mutual respect, whereby absconding is less likely. Remember, all behaviour is communication. What next? Following triage, they should be informed of the likely time to see a clinician, as well as who to contact if they have any questions. Ideally, all patients should be afforded this. Those patients at risk of absconding should also be prioritised for early assessment, or placed in a priority triage category. Parallel assessment of physical and mental health needs should be standard and is desirable. Whilst they are waiting, a balance must be struck between restrictive and therapeutic spaces that on one hand are calming and pleasant, whilst on the other hand are not overly insecure or too harsh and prison-like. Patients considered to be at high risk of absconding should be observed, either intermittently or continuously if at very high risk. Training should be given to staff who carry out these observations. There should be very brief documentation of observations in the notes. Lastly, supervision may be necessary to maintain constant eyes on a person deemed high risk. Their advantages and disadvantages of this should be recognised. What about locking doors? Take care. In the emergency department, you should not lock nor physically hold the door closed on a child attempting to leave unless it is absolutely necessary to prevent immediate and serious harm. Key principles include a duty of care, acting in the child's best interest and ensuring their safety, proportionality, where any restriction must be reasonable, minimal and proportionate to the risk of harm, and always using the least restrictive practice possible. So starting with verbal de-escalation and seeking assistance from others where able. Unjustified restraint or confinement may constitute unlawful deprivation. Clearly, in the moment a child is trying to leave, it is challenging to determine the legal basis for detention. There are some scenarios where it would be unlawful to prevent a child leaving. An example would be a 16-year-old with a normal mental state exam who expresses capacity for deciding to leave, where there are no immediate nor significant concerns for safety and no safeguarding concerns. Ascertaining these points requires a proactive rather than reactive approach and should be at the front of any senior clinician's thinking. Simulation plays a role in training staff for such decisions. Flowcharts such as that shown can aid policymakers and help documentation of decisions made. Of course, there are many risks both in urban and rural settings. Self-harm can occur in the setting of busy traffic, bridges or train tracks, and more besides. Unfortunately, a moment of impulsivity has the potential to end a life. Now imagine a young person known to be at risk to themselves has run away towards a bridge where they were previously rescued from by police. How do you react? Of course, safety first. At the point it is recognised an at-risk patient is missing, the nurse in charge must call security to initiate a stage 1 search. Security will expect clear, concise details and a description. Next, the site manager should be contacted to review the risk. A stage 2 search involving a wider area within the hospital grounds may be warranted and need authorising. Lastly, if it is thought that they have left the premises and are high risk, don't delay in calling the police. So when you speak to the nurse in charge, consider, are they still visible? Who saw them last? Are they a risk to others? Is it safe for clinical staff to follow? Do they have their mobile phone on them? Are they contactable? How much time has potentially passed since their whereabouts was known? Once an initial search has occurred, the nurse in charge has the responsibility to either inform the next of kin of events or delegate this appropriately. Relatives should be updated at least hourly. What about speaking to security? Again, similar information will need to be given with additional input such as, is there CCTV footage? What direction were they going in? Is an extended search needed, including perhaps the car park? And whether there is a risk to others. Lastly, if things are not quickly resolved and or the risk is very high, the police should be involved quickly. Consider appropriate paperwork such as a missing persons form. Ideally, this should be completed prior to contacting the police as it contains all the information they are likely to need. Don't forget to record the police incident number. You will need this during further communication. So, who else are you going to call? What about the young person themselves? What about friends and family who could help? If you are able to get the young person on the phone, keep them talking. Establishing their safety is the priority. Where are they? What are they doing? Where are they going? Are they okay? Is there someone else they want to speak to? Negotiate safe, acceptable options. This may include coming back, it may not. When speaking to the parent and giving them information about what's occurred, remember this is significant bad news. After discussing the bad news, determine if they can help. And lastly, agree what is going to happen next and when you'll update them again. In your department, there is likely to be a long list of people who will have training or experience in managing such cases. The responsibility for this young person sits with a wide group of staff. Consider informing them in parallel to ongoing actions. They may have additional levers or resources. They may have valuable information not known at first. They will know when and if further escalation is needed. Ongoing inquiries will be coordinated through the police. A Datex incident form, of course, should be completed in all cases. If the patient is found, ward staff will confirm the patient's identity, notify site manager, and authorize a stand down of the search, and then document all actions taken. As always, read your local policy, and if you work in the emergency department, be sure to check out RCEM's guidance as shown. Not knowing what to do if a child goes missing can waste valuable time. Acting promptly and properly can literally save lives, especially when the child is known to be at risk of self-harm or suicide. Communication is key, and as ever, prevention through building rapport, documenting their appearance at triage, confirming phone numbers, and more besides is of paramount importance. Know your policies. Know how to notify local security, your duty manager, the nurse in charge, and consider calling the police early.